Hello everyone, my name is Frances Nicdao, and today I'll be presenting my quality improvement project titled Improving Tuberculosis Detection Rates in High-Risk Areas. This project focuses on strengthening TB screening and documentation in a primary care clinic through a standardized evidence-based approach. I'll start with some background and the project's significance, then walk through the methods, results, and implications for nursing practice. Dr. Maria Snell served as my DNP Project Committee Chair and provided guidance throughout the development and completion of this project. Background and significance. Tuberculosis remains a significant public health issue, especially in high-risk areas, and both the Centers for Disease Control and Prevention, CDC, and the World Health Organization, WHO, highlight the need for early detection and treatment. In primary care, one of the main gaps is not that screening never occurs, but that it is often incomplete or poorly documented. At my project site, when I reviewed baseline data for adult annual wellness visits, only about a quarter of eligible patients, about 25.3%, had documented TB screening. This means nearly 3/4 had no recorded TB assessment, which can delay referrals, follow-up testing, and public health reporting. Since national and global guidelines recommend routine risk assessments, standardized screening procedures, and clear documentation, we identified a need to address this gap at the clinic level. The goal of my project was to improve TB screening documentation during adult annual wellness visits by implementing a standardized TB screening protocol, which was integrated directly into the electronic medical record. On this slide, I'll briefly summarize the key literature that informed the project. First, tuberculosis remains a major infectious disease globally, and in the United States, it's estimated about 13 million people are living with latent TB infection, also known as LTBI. That makes primary care screening and documentation especially important. Both the CDC and the World Health Organization recommend routine risk assessment, targeted testing, and treatment of latent TB infection in high-risk groups, and they emphasize the need for clear documentation in the medical record to support follow-up. However, studies note that in primary care, TB screening and documentation are often inconsistent. This can lead to missed opportunities for early detection and prevention of progression to active disease. The broader evidence base also shows that standardized protocols, electronic prompts, and structured tools tend to improve adherence to screening guidelines and increase documentation completeness for preventative services. Finally, quality improvement work in outpatient settings suggests that relatively simple, workflow integrated interventions such as checklists, prompts, and brief education can effectively change provider behavior and strengthen preventative care processes. Those findings supported the decision to embed a standardized TB screening prompt and related education in this project. Theoretical framework. This project was guided by the Plan Do Study Act, or PDSA, Quality Improvement Framework. In the plan phase, we defined the problem, low and inconsistent TB screening documentation, and designed an intervention, a standardized TB screening prompt in the electronic health record, plus brief staff education aligned with CDC and the World Health Organization guidelines. In the do phase, I implemented the prompt within the annual wellness visit workflow. During the study phase, I compared pre- and post-intervention charts and used the Z-test for proportions to evaluate the change in documented screening. Finally, in the act phase, I used the findings to shape concrete recommendations, sustaining the prompt, adding regular audit and feedback, and considering spread to other clinics. PDSA helped structure the project as a practical improvement process rather than a one-time change. I used a quantitative retrospective pre- and post-quality improvement design. I selected this design because the core question was whether documentation of TB screening changed after the intervention was implemented, and existing EMR data allowed us to compare practice before and after the change without disrupting care. The setting was an outpatient primary care clinic, and the sample included 150 annual adult visits, 75 charts from before the TB screening prompt was added, and 75 from after. The intervention was a standardized TB screening prompt embedded in the EMR annual visit template, supported by a brief checklist and staff education based on CDC and WHO guidance. Data were collected via structured chart review, and the primary outcome was simple and binary: whether TB screening was documented, yes or no. Descriptive statistics summarized the sample, and a one-tailed z-test for the difference between two independent proportions was used to determine whether the change in documentation rates from pre to post was statistically significant. This combination of design and methods directly answered the inquiry: did the EHR embedded protocol improve TB screening documentation? The sample for this project consisted of 150 adult patients seen for annual wellness visits in a primary care clinic. 75 charts were reviewed from the pre-intervention period and 75 from the post-intervention period. Patients ranged in age from 18 to 65 years. Overall, the sample was 58% male, which was 87 patients, and 42% female, 63 patients. All encounters were routine annual wellness visits, which was intentional to standardize the visit type and reduce variability in why patients were being seen. The time frame for the chart review was August 31st, 2024 through January 31st, 2025, capturing a several-month baseline period and an initial post-implementation period after the TB screening prompt was added to the EMR. For data analysis, I first used descriptive statistics to summarize the sample frequencies and percentages for categorical variables such as gender and documented TB screening, and the overall age range for context. For the primary outcome, I selected a one-tailed z-test for the difference between two independent proportions. The main question was whether the proportions of charts with documented TB screening increased after the intervention. The test is appropriate because the outcome is binary, screening documented yes or no, and we are comparing two independent groups, pre-intervention and post-intervention. I used a one-tailed z-test because the hypothesis was directional. Based on the intervention, I expected documentation rates to increase, not just change in either direction. The significance level was set at 0.05. This approach directly tested whether the standardized EHR prompt was associated with a statistically significant improvement in TB screening documentation. The evaluation included 150 charts, 75 pre-intervention and 75 post-intervention, from adult annual wellness visits conducted between August 31st, 2024 and January 31st, 2025. Patient ages ranged from 18 to 65 years old, and the overall sample was 58% male and 42% female. Sample characteristics will be shown in Table 1 in the next few slides. The primary outcome was TB screening documentation. In the pre-intervention period, TB screening was documented in 19 of 75 charts. After the intervention, documentation appeared in 45 out of 75 charts, which was now 60% from 23%. A one-tailed z-test for the difference between two independent proportions revealed a statistically significant change in documentation rates. The difference of 0.3467 and a negative 4.29. The 95% confidence interval for the difference was negative 0.49 and negative 0.20. Post hoc power analysis using G-power indicated a power of 0.998 for the observed effect. No secondary inferential analysis were conducted. Sample characteristics also included comorbidities, vaccination status, TB treatment history, and other clinical variables, which are summarized visually in figures 1 to 4. Table 1. Here you see annual wellness visit charts revealed from August 31st, 2024 to January 31st, 2025. Percentages for pre and post intervention groups are approximate to maintain the combined distribution of 58% male, which is 87, and 42% female, which is 63. Here are figures 1 to 4, which show comorbidities among patients with diabetes as being the highest, as we can see in figure 1. Figure 2 shows influenza vaccination status among patients. Figure 3, TB treatment status, and figure 4, gender distribution of patients. These findings highlight the importance of proactive TB screening as a quality improvement strategy, especially in areas with high tuberculosis rates. Early detection, prompt referral, appropriate surveillance, and timely treatment, which helps reduce further health complications and community spread. The significant reduction associated with the screening intervention underscores the value of preventative care and supports the continued integration of tuberculosis screening into standard clinical practice. Limitations. There were several limitations that may have affected the result. First, this was a single-site project in one outpatient primary care clinic, so generalizability to other settings was limited. Second, it was a retrospective chart review, which means I relied entirely on what was documented in the record. If screening occurred but was not charted, it would have not been captured in my data. The post-intervention period was relatively short, so I can't yet say whether the improvement in documentation will be sustained over time or affected by seasonal or staffing changes. Data abstraction was performed by a single abstractor, which introduces potential bias, although a portion of the charts were double-checked. There was no randomization or control group, so other unmeasured factors like concurrent workflow changes could have contributed to these findings. Finally, I did not measure downstream clinical outcomes such as TB case detection or latent TB latent TB treatment initiation, so the clinical impact beyond documentation remains to be evaluated. In the discussion, I want to focus on what these findings mean and how they answer the original question I posed at the beginning of the project. The problem was that TB screening was documented in and only about a quarter of eligible annual wellness visits, which was 25.3%. This meant most patients had no recorded TB risk assessment. After I implemented the standardized TB screening prompt in the electronic medical record, which was supported by a brief checklist and staff education, documentation increased to 60%. This change is both statistically and clinically meaningful. The one-tailed z-test for the difference between two independent proportions showed a significant improvement in documentation, with an absolute difference of 0.3467 and a 95% confidence interval that did not cross zero. In other words, it is very unlikely that this change was due to chance alone. Practically, these findings tell us that the intervention directly addressed the original problem, low and inconsistent TB screening documentation during annual wellness visits, and improved the reliability of the screening process. With better documentation, nurses and providers can more easily see who has been screened, who is at risk, and who needs further evaluation or referral. This supports earlier identification of LTBI or latent TB infection and more timely linkage to public health TB services, which is exactly what CDC and WHO guidelines call for. The findings also reinforce the idea that low-cost, nurse-driven workflow integrated changes like adding a prompt to the EMR and providing targeted education, can have a real impact on preventative care processes in primary care. While we did not yet measure downstream clinical outcomes such as TB case detection or treatment initiation, this project creates a foundation for that next step. So, to directly answer the question of inquiry, yes, implementing a standardized TB screening protocol embedded in the EMR did significantly improve documentation completeness in this primary care clinic, and it highlights a practical strategy that can be adopted in other settings. In terms of implications for practice, this project has several important takeaways for nurses, patients, and the broader healthcare system. First, at the practice level, embedding a standardized TB screening prompt in the electronic medical record gives nurses and medical assistants a clear, consistent structure for risk assessment during annual wellness visits. Instead of relying on memory or variable provider preferences, the prompt serves as a built-in reminder that TB screening needs to be addressed and documented. This helps reduce missed or undocumented screening and increases reliability in day-to-day workflow. For patients, the implications are directly related to safety and prevention. When TB screening is documented more consistently, at-risk individuals are more likely to be identified, referred for further testing, and if indicated, started on treatment for latent TB infection before it progresses to active disease. That can reduce morbidity for individual patients and decrease the risk of transmission within families and communities. It also supports better coordination with public health departments who depend on accurate information from primary care. From an organizational and systems perspective, this intervention helps align practice with CDC and WHO recommendations for TB screening and documentation. It strengthens the clinic's ability to demonstrate adherence to evidence-based guidelines and to produce data that supports quality, reporting, and public health surveillance. Because the intervention is low cost and EMR-based, it is highly feasible to sustain and to adapt in other outpatient clinics without major resource investments. Finally, for nursing practice specifically, this project reinforces the leadership role of nurses in preventive care and quality improvement. Nurses are often the ones who complete intake questions, document screenings, and coordinate follow-up. By leading the implementation of a standardized screening process, nurses help shape safer systems of care and ensure that preventative service like TB screening are delivered equitably and consistently. I'll close with a brief summary of the project, what it has accomplished, what I would change, and how it has shaped me as a DNP prepared nurse. This project began with a clear problem. TB screening was documented in only about 25% of eligible annual wellness visits in a primary care clinic. By embedding a standardized TB screening prompt into the EMR, adding a simple checklist, and providing brief staff education, I increased documented screening to 60%. Statistically, this was a large and significant improvement. Practically, it means many more patients now have a recorded TB risk assessment, which is the first step toward timely evaluation and prevention. If I were to do this again, I would extend the post-implementation period to assess sustainability over a full year and add more outcome measures, such as the number of confirmatory tests ordered, latent TB treatments initiated, and time from positive screen to referral. I would also build in structured feedback from staff and patients to better understand usability, barriers, and ideas for refinement. Looking ahead, my plan is to sustain the prompt at the current site, implement routine audit and feedback, and explore spreading the intervention to other clinics in the organization. Linking documentation improvements to downstream clinical and public health outcomes will be an important next step. Finally, the DNP program has been central to this work. It has strengthened my ability to appraise evidence, design, and evaluate quality improvement projects, interpret data, and lead interprofessional teams through change. On a personal level, I now see myself not only as a clinician, but as a nurse leader who can identify gaps, implement evidence based solutions, and measure their impact on patients, populations, and systems. These are the key sources that inform the project, including Centers of Disease Control and Prevention and the World Health Organization guidance on tuberculosis screening, the clinical practice guidelines for TB management, and the evidence based practice and research texts that guided the quality improvement design and analysis. I'm happy to share specific references or tools if anyone would like them after the presentation. Thank you for your time and attention. I'm glad to answer any questions or hear suggestions about how this project might be adopted in your settings.